see my presentation.
Yeah, sure. Okay, so we can see the slide mode of your presentation. Yeah, so it's full
okay.
full screen now.
Yeah, you can see my screen now.
Yes, it's full screen.
Okay, excellent.
So we'll just wait for maybe another 2 minutes, 3 minutes
Okay,
maximum.
yeah, that's fine. Yeah.
Yeah, so that we have as many people joining in as possible. Yeah, the topic is that sounds very exciting.
Sorry? Well, I'm sure it's nothing that all of you haven't seen or done before. So, but it's good to share these cases.
Oh yes, absolutely. Sharing, I think it really makes a difference. I mean, I don't think any number is too much. So, and I don't think this is a very common thing anyway. This aortic thrombus thing.
Indeed, we don't see aortic thrombus that often, do we?
Well, we're going to see what Tosin has to say today.
By the way, the Ramadan started. Happy Ramadan to everyone.
Thank you very much. Thank you very much. Same to you. Okay, Tosin, I think because you just have 30 minutes for us, so let's better get started. And because it's a recording, so we all kind of are able to listen to this later on as well. So yeah, so just for housekeeping, everybody logged in, please keep your mics off, and it's an interactive thing, so please shoot your questions anytime you feel. Otherwise, you can raise your hands as well. Okay, Tosin, thank you very much. Please crack on.
All right, good to be here and good to share some of our own experience here from St. Peter's Hospital in Chertsey, where we have started to go on this our journey of using ultrasound at the bedside a lot more, and also supporting and teaching our trainees as we ourselves also learn. So this is a case I'm just going to present very briefly of an aortic thrombus in the abdominal aorta for an extreme preterm who had a UAC as well as a UVC inserted for some time. So we'll just go through the short case presentation, talk about how we came across this thrombus, and also use this as an example of how we used point of care ultrasound to manage this baby. So essentially it was an in utero transfer from one of our local hospitals, male infant, 506 grams. Mom had had a ruptured membranes for 2 to 3 days, chorioamnionitis, but she wasn't that unwell with it, and nothing growing at that time from her cultures. There'd only been the opportunity to have 1 dose of steroids on board. Baby was also a breech presentation, so all quite tricky. But the team were well briefed. So baby was, the neonatal team were in attendance at the delivery, and they were able to fairly quickly stabilize this baby on Vapotherm 8 liters per minute as per our practice. As even for the little ones, if they are putting in spontaneous effort, we do try and do DCC and manage them on Vapotherm in the delivery suite. It had an FR2 initially about 70%, had surfactant Curacao given by Lisa. The FR2 came down to 0.45, but importantly, the baby's work of breathing also appeared to be much better. So this allowed time for birthday cuddles, dextrogel as per our preterm pathway in the delivery suite, and then was transferred to the NICU on Vapotherm in about 40% oxygen. So that was coming down. Admission temperature was 37.5 centigrade. The initial venous gas was actually about 7.09, 7.1. The CO2 was about 9, base excess minus 13 with a lactate of 6.7. As they were sorting out the baby, started to have a bit more increased work of breathing. So a fairly early decision was made to intubate, and this was fairly straightforward with a 2.5 ET tube. Length 6 centimeters, which initially I thought, oh, that's very long. That was subsequently adjusted. Was put onto PCAC and VG 5.5 mils per kilo, and seemed to have good gas exchange with that, good air entry, chest movement, etc. The perfusion wasn't an issue. Neurologically, the baby seemed to be reasonably settled, and we don't routinely give our babies sedation on ventilation unless we have concerns about distress or discomfort. The cranial ultrasound scan too was normal. The skin, however, was extremely fragile, peeling off, and actually this was a baby where it was very difficult to get anything to stick onto the baby at that time. Things just kept falling off. And in babies like this, of course, we then don't use, we don't put on ECG leads anyway, but even things like saturations were hard to get a grip on. Sepsis, we started benpen and gent, and we started some fluconazole antifungal prophylaxis, and parents also had good briefing. Decision to put in lines were made. Our local practices, babies less than 750 grams have lines put in. Above that actually is based on whether the consultant feels there's a high likelihood of them not being able to come off the ventilator or off to a poor start. But the lines were put in using our LOCSIP policies. Please feel free to interrupt me at any stage. The comments from the Badgernet were that these lines were inserted easily, measured 7 centimeters, but surprisingly did not aspirate, or unsurprisingly did not aspirate until we were about 6 centimeters. And again, our guideline says don't fix unless you're having aspiration from from both lumens to be reasonably sure you're in a good place. This was at night time. We are also beginning to have ultrasound guided UVCs, or at least ultrasound done when the person doing the procedure is happy with the line, and then somebody, one of 3 of us currently, if available, will come and scan prior to securing. So we're trying to embed that practice, but we don't have enough people yet to make it a standard practice, particularly out of hours. So the chest X-ray was done, which is still our routine unless ultrasound availability is present. We have now set up an email address for POCUS internally. So when people are about to do lines, if we're not around, echoes, lines, long ultrasound scan, they will email the request to us. And we will then have one of the 3 people who are currently doing more of POCUS championing, myself included, as well as my colleagues, Dr. Mary and Dr. Dabo, who has recently joined us. So various stages of expertise and learning of that, but we all put our heads together and trying to encourage that culture. So that was pulled back, and then the following morning had a POCUS scan, which still showed, and I'll show you that in a minute, that the line was still in and therefore pulled back further. From the arterial catheter point of view, there really was no concern about the entry. It was a 3-vessel cord. It was described as going in fairly easily. It was measured by 2 people, and we used a combination of the chart on our unit and NeoMate as well. And over a while, we found out that NeoMate is not always sort of entirely accurate with these babies with their different proportions of thorax to lower limb body. So the first X-ray, I hope you can all still hear me. Yeah, can you hear me?
Yeah.
Yeah,
All
okay,
good.
lovely.
Yeah,
So
yeah, we
the
can
first
hear you.
test X-ray shows that the UVC there, I've got my cursor in it, seems to be in the right atrium. The NG tube is short. We felt the UAC2 was too high. The only thing that seemed to be reasonably in good position, perhaps just short of the carina, was the ET tube. So various adjustments were made. UAC was pulled back. Likewise, the UVC was pulled back and felt to be satisfactory. But lo and behold, as you can see that when our purpose was done to look at the UVC position, I will just play that again. And we have come across this quite a few times on our unit where the UVC is thought to be in the right atrium, but we do an echocardiogram and we find that it actually is going across the foramen ovale and now going into the left atrium. And we've often now talked about the potential consequences, particularly if you were to end up with thrombi in the left atrium, or if the UVC was perhaps to even go into one of the origins of the pulmonary vein, which in itself could induce sort of inflammatory changes, which may in the long term go on to cause things like pulmonary hypertension. So we are using ultrasound to highlight the real dangers of insertion of these catheters, particularly into the smaller babies, those who are less than 600 grams, those who are sort of 22 to 400 gram babies. So going back to this 23-weeker, he ended up with prolonged ventilation for RDS with evolving BPD or chronic lung disease changes at various points using lung ultrasound. Sometimes you couldn't see any A lines at all, just very dense B lines, lots of subpleural consolidation, and also lots of air bronchogram changes. He then ended up with Klebsiella oxytocin growing from the ET secretions. We had discussions amongst ourselves as a consultant body as to how much of this was possibly just colonization versus true infection. But using ultrasound, we're also able to demonstrate that there were changes with perhaps seeing a lot more subpleural and deeper consolidation when this baby's colonizations were present, or actually when the baby's cultures were positive and showing the response with treatment. So we use that as well as the increasing ventilator support required to demonstrate that actually these were this wasn't necessarily just colonization, but there was evidence ultrasonographically of significant changes in the baby's lungs when we had these growths. So that then resulted in an extended course of antibiotics, and coexisting with that, we were also getting growths of Enterococcus faecalis in the blood cultures. So based on those findings and the fact that after the first growth, the baby was clear for a few days, and the subsequent blood culture again grew Enterococcus faecalis. So I was then asked by the attending consultant at the time to come and look for vegetations and thrombi within the heart. And we all know how hard that is to find, and we also have these discussions to say that that is not the gold standard for endocarditis, but it's still worth a search, particularly in a baby who's had catheters in place. So that was what we did. So this was on the back of having had radiologists coming to do the scan, also looking for thrombi in the vessels and not finding any. This is really just a snapshot of one of the lung ultrasound scans we did on this baby. The picture on my left is on the 24th. This baby was born on the 3rd of February. So we're about sort of day 21 in now. And you can see the pleural line. Apologies, these are still images, and I appreciate that it shows a lot more effectively when you've got dynamic pictures. But here you can actually see the irregularity of the pleural line compared to here. You can see much deeper consolidation. You can see lots of sort of confluent B lines with no A lines. And this was over the left chest, which is why you've got the cardiac shadow there. So a bit more imaging to share with you. So the chest X-ray is really just to show you that eventually we did adjust the UAC to a good position. The UVC seems to be veering off on that view, but the film is slightly rotated, and on ultrasound, again, we were able to convince the team that it was it wasn't going into a portal vein, and we showed that view. So ultimately, we actually went for a long line in this baby, and the picture I'm just going to click on now is using a 9L linear probe, which is quite a chunky size probe to use on a 500-600 gram baby. But just placing it in the infraclavicular region, we're able to identify the long line that was put into that. We could then take the UVC out. And if that should play nicely, we can see the long line there with flow around it. We can also see the subclavian artery in that position there. So this is placed in the right, through the right antecubital fossa, and we're then able to track it using ultrasound, using both the linear probe as well as the 12S probe to identify its correct position in the proximal SVC. So again, in this baby, very good use of POCUS, which means we didn't have to rely on x-rays. And when we do these ultrasound scans, we usually get 2 of us to review them. And if there's any doubt whatsoever, we still do get a chest x-ray. So we're in that transition where we're doing a lot more ultrasounds. We currently do about 1,000 x-rays a year on our unit. And I asked specifically for that data because I want going forward to see how we can manage to, as a QI project, to safely reduce the number of x-rays we perform on babies for lungs, lungs, and hearts. In terms of cardiovascularly, this baby had quite a significant duct, and this was a decision was made to close this based on ventilator dependency plus the echo findings, all consistent with volume loading of the left heart, both LA and LV. And we do take quite detailed measurements. We look at LVIDD, we look at sort of flow in the LPA, we look at flow reversal in the aorta. So we do use quite a composite and comprehensive set of criteria to decide on treating these babies, recognizing that treatments can still have long-term complications. So the first course was day 4 to day 11. There was evidence of good effect, but baby then got septic and then clearly reopened the ducts, and we could then see torrential flow again, and hence following an interval, then had a second course. And we again went for paracetamol on the basis that this baby had some GI concerns. And also importantly, that paracetamol had worked the first time. So we were fairly optimistic that it would work again, and it did actually do that. And by day 5, we could see nice constriction, and the duct was now tiny. It was during one of these scans that we then accidentally discovered that there was what appeared to be a small thrombus at the time near the origin of the superior mesenteric artery. But this wasn't investigated as it was thought to be small and not quite extensive at the time. I was just going to show you briefly this baby's renal profile because I'm sure people will say, well, could this thrombus have been explained by baby being dry in view of the very loose skin, the extreme prematurity, and in spite of this baby being nursed in about 85% humidity with fairly aggressive and scrupulous attention to fluid and electrolyte management, particularly in the first few days. We had a peak sodium of 149 on day 2 to day 3. We count the day of life as day 1, rightly or wrongly, and this baby was born at about 1900 hours that evening. But in the first few days, we don't actually use day 1, we use how many hours old they are, and we use a combination of that, weighing daily, 8-hourly fluid balances and electrolytes to manage our fluid balance. So actually, when we look at this renal profile, we see that on about the 13th of February, day 10, we've had a peak there up to about 153 of the creatinine. This was blamed by our clinicians at the time on the PDA, and I'm always defending the docs because it still gets wrongly blamed for lots of things. Anything goes wrong with the baby, a few more bradys and DSATs is the docs. There's some renal dysfunction is the docs. Everything gets blamed on the docs, even when the doctor is just an innocent bystander in the general scheme of things. If you look at the urea as well, we can also see an early peak there, which was up to 17. We couldn't quite explain that, but it came down very sharply. And then there was a much later rise, we probably tied in with when we were increasing fortifier, and then we backed off a bit, and then that came down as well. So at this stage too, renal Dopplers were done because of the concerns about this possible thrombus. And the comment from our radiology consultant, who's very experienced and highly skilled, showed possible, couldn't see any thrombus, but this baby had quite significant gaseous distension at the time. But more importantly, there was good renal, arterial, and venous Doppler waveforms, which were quite reassuring at the time. The UAC eventually came out on day 9 as deemed not required anymore. There were no known clinical complications. One of the practices we have on our unit here at St. Peter's is that on a daily basis on the consultant ward round, we have to sign as to whether any central lines stay in or not. And you have to then give the justification. So we do that every morning round to say UVC to stay in and why, UAC to stay in and why, and it has to be a consultant signing it. So even when the registrars do the rounds, that important aspect really still has to be countersigned by a consultant to agree with the reason for the lines staying in. So on day 27, so baby now about 4 weeks old, corrected gestational age 26 weeks, I was asked to do the scan because of the recurring E. faecalis bacteremia and the concern from the attending neonatologist that could the thrombus be seeding and causing this reinfection. However, the baby clinically was well, the CRP still remained normal, the white cell parameters were fine, the platelet count was fine. So really didn't have anything going, but we still knew that this bug, in spite of the right antibiotic, still seemed to be seeding Enterococcus faecalis from somewhere. Probably they got, but a thrombus was a concern. So I did the scan and I used the 9L probe and I actually went laterally and I was quite surprised to see a structure in the aorta, which I described as a linear unobstructive echogenicity distal to the SMA, but extending into the left common iliac branch. I measured it at about 2 centimeters, and I felt that the abdominal aorta was normally pulsatile with a normal pulse wave Doppler pattern. I was also mindful that I'm not a radiologist, and when we're doing these scans too, there's that overlap between what we are trained and able to do and what is actually more within the radiologist's remit. And I think those lines are increasingly becoming blurred. And I'm also recognizing that actually there are some images that we as neonatologists, by virtue of doing more and more scans, that we are probably better at getting and seizing the right opportunity for the baby to get those views compared to the radiologist, but we still do need to put heads together in terms of being clear about the anatomy and also the differentials. So we visualized the IVC and hepatic veins and SVC. There were no vegetations or thrombi seen, and there was nothing intracardiac. So this was fed back to the radiologist, who then came and did a joint scan and was then also able to confirm my findings there. So these are just pictures to show you what we initially saw. So that 2802 scan, you can see that irregular linear finding there. Those are the kidneys on both sides of it. So it does actually extend to the origins of the kidneys. And what we can see on the right there is, again, you can see flow into the kidneys there. That's the left kidney there on that view, but we can still see good flow. I'm hoping that this allows you to see it in a more sort of dynamic image view. So there again, we've got the linear irregular thrombus sitting in the aorta. We can see the kidneys there, but importantly too, we're able to demonstrate that there was good flow. So we knew it wasn't obstructing the kidneys, and we knew it wasn't obstructing flow into the distal extremities, but we were quite surprised at the size of it. And I think for me, one of the advantages of showing these pictures to our trainees is that it's also highlighted to them about the potential complications of these lines. I'm moving away from just saying, oh, it's great to put in these lines, but also to be increasingly aware as we put them in these smaller and smaller babies, that these are still fairly giant catheters And even when they are removed, they can still leave signs that are hidden and may potentially cause problems. So just coming on, sorry, I'm whizzing through because I only have half an hour and I have a grand round at 12:30. So pardon the speed at which I'm talking. So just really a brief summary about arterial thrombosis. So in the neonates, they're pretty much nearly all associated with arterial catheters. Of course, you can get thrombi occurring from a range of different things. We know that dehydration can predispose to that. We know that polycythemia can predispose to that. And then we talk about the rarer things, your protein S, protein C, homocystinuria, all those sorts of things, von Willebrand. But we know that largely speaking, that the vast majority of arterial thrombi in the neonates are typically associated with catheterization. So they are also related directly to the site of catheterization, as well as the duration at which your catheter is in situ. There is some evidence that using prophylactic heparin, as most of us do, may reduce the risk somewhat. And the incidence varies hugely. I suspect that this is under-recognized, but it's quoted at anything from about 8 to 20%. But most of these are asymptomatic. They're sitting down there quietly. They're not causing any problem. We don't know they're there because we don't go looking for them routinely unless there is a problem. We have actually now started on the basis of this case to routinely look at the aorta for all our babies who have UACs in, regardless of the length of time they're in, and documenting those so that we have a baseline, and we're doing that as a sort of small study. If they were to give symptoms, which I said are quite unusual, this could be things like hypoperfusion, blanching of the extremity, coolness of the periphery. The nurses may say that they are unable to get good saturation profile from that particular extremity, and you may not suspect at the time that it's because of a thrombus lodging itself in an extremity vessel. To things like frank ischemia, with more significant changes, particularly in the extremities or around the bottom, the sacral area. We know that these can give you renal impairment. We actually suspect that with this baby, the transient renal impairment he had with the rise in creatinine, in hindsight, may have been because of the presence of this thrombus, which may have been higher before, but then changing in position. But we have no way of proving that. Clearly, hypertension too can be a symptom of an arterial thrombus, and it can actually mimic severe coarctation as well. So that needs to be borne in mind. And depending on whether you've got embolization into intestinal vessels or the spinal arteries, you may end up with things like necrotizing enterocolitis, and even worse, something like a spinal cord infection. If you read through various, so I did a troll of various guidelines. I also looked up an interesting paper on the up-to-date website, which has quite an interesting article on neonatal thrombosis, which I will recommend reading, and is available through Open Athens. I'm also quite happy to email it to people if they prefer me to do that to them. But it talks about that the main indication is a significant impairment of blood flow to either the vital organ or an extremity. And in that sort of situation, you're very justified in considering thrombolytic therapy, for which there's also very little evidence, particularly in this age group. In fact, when you look at the use of low molecular weight heparins, like enoxaparin, danzaparin, talzaparin, there are limits saying that you shouldn't be using them less than 32 weeks gestation. And here we have a 23-weeker who was only just coming up to 4 weeks of age when we picked this up. Unfractionated heparin can also be used, but again, there are significant risks of bleeding into various sites, including the brain, hematomas. I had a discussion with a colleague, Ane Kulkani, who actually introduced me to this group, to ask him what he will do and what they do. And it's pretty much the same thing. It's sit and wait and monitor. We did consider whether we should discuss with the hematologist, but we felt that overall that they had less experience than we did in managing these conditions. And for that reason, we decided that we would hold off discussion with them, because we had something that didn't seem to be causing a problem. So the question of to treat or not to treat, we decided to hold tight, but there were some of my colleagues who were in favor of trying to do something, but eventually won over by the principle of first do no harm. So we're still monitoring clinically with weekly ultrasound scans. The measurements really haven't changed, the size hasn't changed, but there is still good perfusion to the kidneys and to the lower extremities. My colleague who had a look last week, Dr. Mary, also did femoral Dopplers as well, and we could see nice Doppler pulsation on that. And of course, we've asked our nurses and our clinical team to be mindful, to keep an eye on the urine output, and to also continue to review the baby's lower limb perfusion. We're hopeful that this will gradually resolve, but recognize that sometimes it can take weeks and weeks and weeks before it does so. So we don't feel in general that there's a lot of expertise on managing these sorts of things. We do feel that we've probably missed a lot more and attributed renal dysfunction or transient hypertension to other causes. And as I said, the doctor has often been blamed, even though it might be an innocent bystander. We still need to consistently warn about the dangers of catheterization in this population. We recognize that there's a need for it, but the timely removal, trying to get them onto feeds, trying to use other ways to monitor them transcutaneously, for instance, rather than keeping lines in for this hidden but potentially very significant complication. And in terms of technology, we are beginning to realize that when we're managing 23 to 25 weekers, a lot of the tools, the catheters, the chest drains that we have are not really designed for this group of babies. And therefore, we're more likely to see more complications. How many times have we thought, oh, wouldn't it be nice to have a 2.75 ET tube because the size 3 is too big, and these babies have grown bigger for than their need for a 2.5, and you obviously can't use a cuffed tube. Likewise, the arterial catheters and the venous catheters were designed for bigger babies. And it's about time we started to try and push our manufacturers into redesigning lines that are tailored for this group of babies, and perhaps impregnating them with things that can help to reduce the risk of thrombosis. And so in conclusion, we are using POCUS more as an essential multi-purpose cord site tool. I'm learning from you folks out there. I was also in Paris to do my long ultrasound course many years ago. I'm glad to see people like Nadia on board. But by sharing our expertise, by sharing our learning, we're all learning what our limitations are, how to improve on those. And I think working with our radiologists is a very good way to improve our skills and diagnostic spectrum safely. We still need to be aware of unexpected findings. We also need to be aware of artifacts as well, and remembering the principle of first do no harm, and recognizing that our journey is still very much in its infancy, but it is a very exciting one indeed. Thank you very much for listening. Any questions or comments?
I can't see any hands raised, but dear all, yeah, Tosin needs to go. Please shoot your question.
Thank you so much, Tosin. That was amazing.
Vikash, you have your hand up.
Hi, is it okay? I thought Mahmood was asking a question.
Yes, please. Yes, I will take another 5 minutes max.
Mahmood, do you have the question?
No, I just wanted to say thank you very much.
Right.
That was fantastic. Just you're doing amazing job with all POCUS potentials, and from lungs to lines to echo. So that was fantastic. Thank you very much for this nice case.
Hi, thank you, Tosin, for sharing the case. I'm very impressed with the consistency in the practice in your unit. Is you've developed a process where you are engaging your colleagues and all to regularly to do point of care ultrasound, setting up email group. It's quite impressive way forward in terms of. But I'm also impressed with the way that every day you guys, as a consultant colleague, has to decide. So, what's your mean age for UAC, UVC positions? Actually, how long do you keep the UAC and UVC generally with such close, monitoring and stewardship?
We try and keep the UACs in for anything up to about 10 days. It depends on the
Okay,
baby.
that's
Yes, it
okay.
depends on what they no. It
Mm.
depends on how the baby is doing. So it's a clinical issue, but beyond that first few days, we start to pay even more closer scrutiny to it using ultrasound as well. With the UVCs, if the position originally was not right, we have a lower threshold to replacing it with a long line early on. So UVCs that have already been adjusted, once or twice, we would be more keen to take them out and go earlier for long line in those babies. And particularly where we anticipate that it's going to be a long road. And of course, those 23, 24 weekers will fall squarely within that category. But what we try and do is to make sure that wherever possible that the long lines are inserted with ultrasound guidance, so that again, we get it right first time. So what we're trying to push with our team, trying to get all of the old habits where people will put in lines a little bit extra, so, and then in the intention of pulling it out later, we say, no, let's get in the right place first time and secure it then. So if it involves deferring it until one of the POCUS teams is available, then we will do that if it is clinically appropriate to do so. We are also now, so we've stopped calling ultrasound meetings, cranial ultrasound meetings. We now call them POCUS meetings, where we share long ultrasound scans, long line scans. So we moved away from just looking at head scans only. We look at a range of scans to enforce learning. And with the trainees, because babies have two lungs, if we have two trainees, we say, you do the left lung, you do the right lung. And that way everybody gets some shared learning and expertise. And we say, don't matter, just take the pictures, we'll review them. And we give people credit for being bold enough to think about long ultrasound rather than reaching for the X-ray in the first instance.
No, thank you. I like your idea of one lung each training. that was quite good. No, so you do keep up to 10 days. So that was I wanted to know actually,
Yes.
Particularly in 22, 23, 24 weeker. The benefits of UACs are significant, particularly when you are monitoring the hemodynamic as well as blood sampling and other stuff. The issues are that they sometimes become too much of blood, despite of high logging maintenance, blood log, they still become victim of iatrogenic excess bloodletting and then get blood transfusions. Just in regards to your first echo, which you showed, where you said the point of care, on the X-ray, the UVC did not look that deep, but you said it did look as cross the foramen ovale and gone into left atrium. Did not feel like that actually. So was it very because very rarely UVC crosses the. It's more the natural course for UVC, I believe is or lines is through right atrium to right ventricle and then pulmonary artery. It's more difficult for them to cross the.
I think what we're seeing, and we've seen this on a few scans, because when the babies have the lines in initially, they have a bodygram, they have a combined chest and abdo X-ray. And actually the angle of collimation is not so much focused on your lines. So your lines can appear to be just in the right atrium. When you come along and do your echocardiogram, we have seen quite a few cases which we've used for teaching, where the line is not just in the right atrium as reported by the radiologist, but has actually wandered across the foramen ovale. It's almost as if it's doing an atrial septostomy. It's gone right across and is now sitting in the left atrium. So effectively, you could be doing arterial sampling from those lines without knowing that they're there. And again, one of the beauties of ultrasound scan is that precision, and we can pull it out and see. So we use both the 9L and as well as the more cardiac specific probes to confirm that this is actually crossing the PFO.
Very interesting to see that it actually, despite an X-ray, looking so, because I do all my lines, I do a point of care, but not everybody in our unit do. A few of us do it there. But again, it re-emphasizes the importance of point of care to, I've seen lines going all across coronary sinus and all the places. So again, it emphasizes the use of point of care. Thanks for sharing. Thank you.
And I'm so excited. I've got some good news to share. I've just had an email this morning that our new Vivid S70 with the hockey stick probe has only just arrived. We've placed an order for it over a year ago. and it's just arrived. So it's like Christmas has come early for me this year, or maybe it's a Ramadan gift for me.
So does this S70 have a needle tracking system in it or not?
So does it have a what tracking system?
Needle tracking.
No, but I would quite like you to tell me about that, because it sounds like it's a good thing to have. So it's something that I will look into.
Well, I think it's inbuilt, so if it's not in this model, because we have the same machine,
Okay.
and disappointingly, it's not a software; it has to be built in. So so I went through this shock as well, because this is a new machine; it doesn't have it. But Virginia, I think she's here right now. She has a machine that has a needle tracking system built in it.
Okay. Right. Thank you all. It's a great pleasure to have presented what we're doing here at St. Peter's with you and shared a case with you. And if anybody wants, as I said, neonatal, not the neonatal, the UpToDate has a good article on the thrombosis. I'm quite happy to send a link, but I'll just throw it into our WhatsApp group in case anybody wants to go and have a look. But looking forward to next week's talk.
Thank you very much.
And bye for now.
Thank you.
Thank you very much. It was amazing talk. Yes.
Happy Ramadan.
Thank you. Okay, thanks everyone for joining. See you later. Bye.
Okay. Bye bye then. Cheers. Thank you.
Thank you.